Well, hello, I'm back. And today's topic is, again, surgical pathology of the ovary. We're going to cover the less common epithelial stromal tumors, specifically endometrioid tumors, transitional tumors, and maybe a few other little details as we go along. We appreciate you being with us, and we hope that you'll find some things of practical use, both in terms of preparing for practice as well as in actively taking care of patients who have these neoplasms involving the ovary. As before, our purpose is essentially threefold: to cover the differentiating factors between endometrioid tumors as well as other lesions, touch on some of the nuances of maybe the less common neoplasms and the benign lesions that may occasionally be confused with these malignancies. And then we'll touch on some of the staging and reporting issues in these ovarian cancers, because those certainly come into play from time to time. So let's launch off to begin with the endometrioid tumors and think about how we can come to get our arms around those lesions. These are a small percentage of ovarian tumors overall, but 10% of cancers, and a vast majority of those ovarian tumors that are in stage 1 will be endometrioid type. So one clue right to begin with: if you find a stage 1 carcinoma, make sure that it's not endometrioid carcinoma before you make another diagnosis. There are benign and borderline and malignant variants. These are all more common in women over 40, just as endometrial cancers within the uterus are more common in that setting as well. And no surprise there, because there are many common drivers of these endometrioid type tumors. Not infrequently, endometriosis is the other underlying factor. A significant number of these patients have endometriosis in the other ovary or elsewhere. These tumors also do have an association with hereditary non-polyposis colon cancer syndromes like Lynch syndrome, but they are certainly very associated with hormone-driven development. That said, I will state that routine testing of these ovarian tumors to exclude the presence of microsatellite unstable situations is warranted in these tumors, because that's going to help to guide treatment. Now, grossly, as expected, here's a stage 1 tumor, the uterus here on the right, the other ovary that's benign, and then an enlarged, partly cystic, partly solid ovary with a very fungiform type of surface appearance. Some of these tumors, as I've indicated, will have associated endometriosis. Here's a nice juxtaposition of an endometrioid adenofibroma at the base and endometriosis, typical endometrial type mucosa on the surface. Here you can see, again, this endometrioid type glands with a fibromatous background stroma. Now, it's no great fault if you looked at this and thought, gee, that looks very serous. And that's clearly one of the differential factors in this situation. If this is all you have, a serous or have a simple adenofibroma, is it worth bothering about to make a clear-cut distinction between endometrioid and serous? Not necessarily. It's not going to make any difference in the management of the patient, and probably in the long-term follow-up would be similar as well. Features, though, that may steer you one way or the other are certainly the identification of any sort of squamoid elements would be clearly unexpected and unusual with serous neoplasms, but expected and common with endometrioid lesions. So finding squamous morules, these nests of squamous epithelium, is typical in endometrioid tumors, whether they're in the benign adenofibroma realm or whether we're looking at an endometrioid carcinoma. Borderline tumors in the endometrioid category are a little bit more problematic. They can have sort of a polypoid or papillary appearance, similar to serous neoplasms. And they generally have very mild cytologic atypia, where, if you become more serious at it, then you may be looking at something more like intraepithelial carcinoma in a borderline tumor. Fortunately, these lesions, together with others, as long as we have a small volume of invasion or a small volume of atypia, these have all behaved in a fairly benign fashion. So here's an example of what this might look like. You can see a more complex pattern, still fairly well organized and columnar cells without a lot of crowding or pseudostratification. But the glands are crowded. The glands are close together, and there is some nuclear enlargement here that would go along with the picture kind of either of endometrial atypical hyperplasia, or in the ovary, we would call this a borderline tumor. Fortunately, you won't see those borderline tumors very often, and so that's not a problem that's commonly encountered. The invasive neoplasms typically have infiltrative invasion, typically do not have an infiltrative pattern of invasion, but usually it's more of an expansive and therefore potentially under-recognized invasion. You can have a variety of various variants from secretory to spindle cell with papillary and sex cord-like lesions, all within the intermediate realm of possibilities with these invasive neoplasms. So here's an example. Up at the top, you see complex papillary glands, hyperchromatic and irregular in their appearance, with an underlying adenofibromatous component that has endometrioid characteristics. And then you see some sort of in-between areas where you begin to get a little of this red secretion, a little bit bigger cells, and begins to look a little bit more concerning for malignancy. This would not be infiltrative in growth. This is adenofibromatous type of pattern, but this may have expansile type growth. Here's another example of this more expansile, and that's why exophytic, intracystic type of growth that you can begin to see. You can see that this has a very complex architecture, some solid areas, and this probably would qualify as an endometrioid carcinoma grade 2 because of some of these more solid areas with more cribriform and small gland, and here's more solid epithelium growth here, making more than 5%. Here's a higher magnification, and I'm sure that if you took away the caption here, that many of you would say, "Oh, that looks like papillary serous carcinoma," and it can. That's certainly in the differential. You have a hyalinized stroma, you have a single columnar and papillary pattern epithelium with not too much in terms of differentiation between a more serous and endometrioid type of epithelium. So not surprisingly, sometimes these are mixed, and you have both present as well. Here's another pattern that looks even more micropapillary, again, with a little tufting or fringing of the surface epithelium. This could very easily be mistaken for serous carcinoma. This is one situation, however, where subtyping would be useful. And so doing the extra effort of definitively categorizing it as endometrioid versus serous is an important step to take once you have established a malignancy is present. Of course, if you have squamoid memorials like we see here in conjunction with a carcinoma, that's going to put it squarely in the endometrioid category and eliminate any concern about serous differentiation. Here's another pattern that you can sometimes see, this sort of a trabecular pattern of elongated and chain-like nests of cells with sort of perpendicular oriented nuclei, not much in the way of glandular lumina. This could easily be mistaken for a sex cord tumor, perhaps granulosa cell, or even a Sertoli type tumor. Here's another example of this sort of potential confusion with a more glandular pattern, potentially mimicking a Call-Exner body. type of pattern. The mucin, however, is distinct from what you'd expect or find in a granulosa cell tumor. So that's one very simple way to rule that out if it's a consideration. Because we can have these very poorly differentiated squamoid areas or solid areas, you may have other considerations, again, mimicking a granulosa cell tumor. And since granulosa cell tumor can have sort of mucinous or mixed components, making the distinction and clarifying that is an important differential diagnosis to clear up. Here's again another pattern, a more spindle cell pattern, and we can see spindle cell patterns in endometrial carcinomas that could mimic, again, a sex-scored stromal tumor of like a fibromathecoma or other type of stromal neoplasm. Again, these would usually have somewhat different borders and margins, but if you had been compromised in your ability to evaluate things grossly, that might occasionally come into the differential. Here's yet another pattern, this sort of a trabecular pattern with a very hyalinized stroma that can look very much like the world of various other stromal tumors, or potentially even a carcinoid type of tumor or something of that sort. Again, immunohistochemistry and comparing other areas of the tumor, sampling it, will be very important. When we start to think about how we will work these up, there are several markers that are useful and fairly specific for endometrioid histology. CK7 not specific, EMA not specific, but clearly define them from other stromal neoplasms, which would not have that marker. Vimentin positivity in conjunction with the cytokeratin positivity is quite specific for endometrioid carcinomas. There are a few other carcinomas which express both markers, of course, but not in the GYN tract. And then other hormonal or derivative markers like PAX8 can be helpful if your differential includes non-gynecologic neoplasms or non-epithelial gynecologic neoplasms. Will typically be negative for WT1, be wild type P53, and have a splotchy or a scattered staining only with P16 rather than the block-like staining of high-grade serous carcinomas. Now, underlying this are a number of mutations that can be fairly common in the low-grade tumors, the beta-catenin gene, P10, KRAS, and PIK3CA, all can be mutated. And this sometimes is helpful, particularly when you have a tumor occurring in multiple sites, like the endometrium and the ovary and so forth. So we'll talk about that in a moment or two here. The differential diagnosis, as we've already alluded to, can include serous tumors, potentially mucinous or clear cell tumors, mucin-poor, mucinous adenocarcinomas, not very often. Yolk sac tumors can have a sort of endometrioid tumor pattern, Sertoli cell tumors, Sertoli-Leidig tumors, the fatwa, ependymomas, and various metastatic lesions from both the endometrium as well as GI and other sources can occasionally enter into the differential of endometrioid tumors. And since we don't see as many endometrioid tumors as we would say serous tumors or other things, bearing this differential in mind is always useful. So let's talk about the dilemma of what we do when we have tumor both in the ovary and in the endometrium. Essentially here there are three possibilities. So the first of these is that the endometrial tumor is primary, and what we're looking at in the ovary is a metastasis or secondary tumor. So in that scenario, we'd like to see similar grade and appearance of the tumor. We'd like the endometrial tumor to be larger, bulkier, and the ovarian tumor to be smaller, having come later. We'd like the endometrium to show some sort of a precursor lesion, a hyperplasia. And generally, there should be myometrial invasion of some significance. This may either have direct extension or vascular space invasion. Any of these higher risk factors in the presence of a concomitant and ovarian tumor would favor spread. Additionally, if we have elsewhere, if we spread to the peritoneum or to other lymph nodes and so forth, typical of endometrial carcinoma, then that also would argue for that. If our ovarian tumors are bilateral or have multiple nodules, as opposed to a single dominant nodule, that would, again, presage and prefer an endometrial primer. We would want to see absence of ovarian endometriosis. Preferably the tumor is present in the hilum, may be associated with vascular invasion or surface involvement, and so forth. And then finally, ploidy differences between the two tumors and or genetic or karyotypic abnormalities should be absent in the state where, or excuse me, similar in those two tumors to imply that these are derived from a common ancestor. So that's the first scenario. What's the other scenarios? Well, the ovary metastatic to the endometrium. This is possible, not as common, but possible. The cells can pass through the tube and plant in the ovary, excuse me, plant in the endometrium. So again, they would be similar tumors, but the ovarian tumor would be the bulky, large tumor, and the endometrial tumor would be smaller. We should find endometriosis as a precursor lesion. The tumor should be heavily involving the parenchyma of the ovary, not just on the surface. There could be direct extension from the ovary to the, say, the outer wall or to the pelvic side wall as well, and spread elsewhere is typical of ovarian carcinoma. We would like to see it be a unilateral mass. And in the endometrium, an absence of hyperplasia. Again, since sometimes this is a field effect, that can be difficult to demand that. And again, we would expect the tumors to be ploidy-wise and genetically, phenotypically similar. So final option then, of course, synchronous independent primary tumors. And this is sometimes the harder position to defend. Histologically dissimilar. Well, grade 1 versus a grade 2. Lots of squamous differentiation versus no squamous differentiation. Clear cell areas, no clear cell areas, those sorts of things. No or very superficial myometrial invasion only. No vascular space invasion. Background of atypical hyperplasia. The absence of spread of this endometrial tumor. No extension into the other organs. And again, a unilateral tumor located in the parenchyma without vascular space invasion or surface involvement or involving the hilum. And then the absence of other spread of the ovarian tumor. So it's still a stage 1 ovarian tumor, and we happen to have a concomitant development of an endometrial tumor. Ideally, we've also got endometriosis, so we have the fertile field is present. And then if we have to push ourselves further to make sure, we would want to see different ploidy indices or different molecular genetic or karyotypic abnormalities. Again, that's not always possible, and sometimes you can still have similar genetic factors because really we're dealing with a field effect where, say, hormonal stimulation, fertile field of background with endometriosis, background of maybe Lynch syndrome or something of that sort could predispose to concomitant or near synchronous development of tumor in both sites. Well, behavior. How do these two tumors do? Generally, they do quite well based on stage. 70–80% survival at 5 years if a stage 1 tumor, but then obviously with markedly declining survival as stage becomes progressively advanced. However, more recent data, and this is, I think, manifest in our experience here as well, that the survival for stage 1 and 2 tumors can be really quite good, 90+%. And the therapy even for advanced stage tumors is improving as well as we refine the parameters and understand more of the molecular genetics behind that. If there are mixed components, that may drive the behavior according to the more mixed type. Well, another related tumor is the malignant mixed mesodermal tumor, or the malignant mesodermal mixed tumor, or the mesodermal mixed malignant tumor, whichever order you'd like to put it in. These are unusual. We do see them. They are rare, accounting for less than 1%. And these are usually elderly patients, much as the case is seen in the endometrium with these tumors. They can be associated with serous and undifferentiated carcinomas, but occasionally can be seen in the setting of endometrioid background with that as the component of the carcinomatous element, because sometimes they can also arise in endometriotic cysts. And only about a third are bilateral. Differentially, we'd be concerned about undifferentiated carcinoma or endometrioid carcinoma with spindle or corded components. And the interdigitation of this, differentiation and grading of the tumor may play a role in this as well. You can have surface carcinoma with sarcomatous mural nodules. We saw that in some of our previous lectures as well. That immature keratoma can have immature mesenchymal elements that can look malignant, although they usually don't look quite as bad as the carcinosarcoma lesion. And then poorly differentiated Sertoli tumors with heterologous elements can occasionally look like, well, by definition, it has a sarcomatoid component with that. So ruling out that we don't have a Sertoli-lighted tumor is important. Endometrial stromal sarcoma with sex cord-like elements, not very similar, but for the sake of completeness, we include it. So to sort of summarize here, what we've talked about today with endometrioid tumors, and contrasting that with the other epithelial tumors that we've touched about, we see that serous are the most frequent, endometrioid the next most, and followed by mucinous tumors. Bilaterality is much more common with serous tumors, less common with mucinous and endometrioid tumors. The mucinous ones tend to be the big ones, and the fluid tends to be different between these three: clear in the serous tumors, slimy and viscous with mucinous tumors, hemorrhagic as expected here. Coexistent endometrial hyperplasia, very unusual with either the other two tumors, but present in endometrioid tumors in a 10 to 20, 30% range of cases. The epithelium can be somewhat similar, and so that's not always a useful differential. Squamous metaplasia, if it's present, is very helpful. Cilia, hardly ever seen versus frequent in serous tumors, especially the low-grade lesions. And seminal bodies present in serous lesions versus not at all with endometrioid tumors. So let's just take a quick look back at the malignant mixed mesodermal tumor. Here we see the malignant cartilage tissue with very bizarre pleomorphic chondrocytes, then closely transitioning to an epithelial component here. Now, there's another tumor that needs to come into the consideration here, which occasionally can be seen in the GYN tract, more frequently probably in the cervix and uterus, but occasionally in the ovary as well, and that's the Mullerian adenosarcoma. Again, this tends to be unilateral, older patients, sometimes cystic and solid, and it usually has associated endometrioid or serous type epithelium with a very pronounced sarcomatous overgrowth, maybe sex cord elements and so forth. This tends to spread and to recur locally because it's a difficult tumor to control. So it looks a little bit like this. You can see the sort of multi-lobular, blunted papillae type of pattern, a cyst wall here on the side. And under the microscope, it looks like the adenosarcoma lesions that we see in the breast or in the cervix or lower uterine segment. A very cellular cambium layer surrounding the cystic spaces or the lining the capillary structures, and a very bland epithelial component with no significant atypia. Here's a higher magnification view, and again you can see this condensed stroma, which will be mitotically active. The atypia may be relatively mild, but it will be mitotically active. Here you see a couple there. And then a very bland epithelium. The other thing, of course, about the stroma is it tends to be bulky and to form a large mass. Another lesion that can occur occasionally in the ovary, endometrial stromal sarcoma. Usually, again, this is unilateral, these lesions, and may have an endometriosis background. Tends to be less infiltrative in the ovary than, say, in the uterus, and may have more fibromatous areas. These are, again, usually CD10 positive, hormone positive, and the JAZF1 gene rearrangement. There's a couple of partners genes that can be involved with that, including FUS and I believe one other. So that's an important differential and helpful finding at times to make the diagnosis and support that diagnosis. Here's an example. You can see the delicate vasculature here on the right of the endometrial stromal sarcoma. Here a more fibromatous component, less typical of endometrial stromal sarcoma, but may be an area of involvement still. Differential diagnosis would be, of course, metastatic tumors. Diffuse granulosa cell tumor could be, especially the more poorly differentiated ones. Stromal hyperplasia or thecosis, not usually a big problem with that because that doesn't usually form a mass, but certainly a cellular fibroma or thecoma could entertain some challenges with that as well. So let's move on and talk about clear cell tumors and think about how these play into these less common less common ovarian features. First off, benign clear cell lesions are exceedingly rare. Many people have practiced their entire lives and not seen one. So if you are fortunate enough to see one, count yourself fortunate, but don't be diagnosing it every week. Borderline tumors are uncommon as well. They account for less than 1% of all ovarian borderline tumors. But there are a few clear cell adenofibromas or clear cell adenofibroma components that can give rise to clear cell adenocarcinomas. I think we have a video that goes along with this particular entity. The other thing is that it may be somewhat population specific. And so there are some Asian populations where clear cell carcinoma is more commonly seen for some reason, and maybe the more common lesion associated with endometriosis. So there may be something unique in the diet or the genetic background that is driving that, and certainly a topic worth investigating. Here's a clear cell tumor. It has a fleshy area over here and then a more spongy area on the right. This is the adenofibroma component from which the carcinoma has arisen. So here's a clear cell adenofibroma, and if you think, gee, I might call that a serous tumor, well, maybe that's part of why they're rare, is because we either don't recognize them. But I think, again, immunohistochemistry could be useful, but may not be pertinent in the setting of a benign tumor. A little bit more atypical or borderline lesion. Here's one where we see some atypia and some small nested groups. So this is an area where we wouldn't necessarily make the diagnosis of confluent invasive adenocarcinoma because we still have sort of the native adenofibroma type stroma, but the epithelial component is showing enough atypia that we would at least want to call it borderline and recognize that the behavior may be worth following and also evaluating for any evidence of spread or de-differentiation or development of malignancy. Here's some examples of what the clear cell carcinomas would look like, and we see that, again, there's more cellularity. The glandular structures are more closely opposed with one another. There's variability in size and shape and configuration, maybe some single cells in the stroma. And we can, of course, recognize the very pronounced hobnailing of many of the cellular features in the larger nuclei, as well as the clear cytoplasm that we have used to name this tumor. Here's more features of this. And again, you can see how it has some similarity to papillary serous carcinomas. Not all of the cells have very pronounced clear cytoplasm. Not all of the nuclei form hobnails. And so not infrequently, serous carcinoma enters into the differential diagnosis. And things that can maybe help us distinguish that, one would be this very hyalinized or fibrinoid nature to the papillary cores. So that's one feature we might look for to make that distinction. It almost looks like colloid in some circumstances. It's very eosinophilic, very fibrinoid appearing. And on occasion, we can also see the hyaline droplets as well in these lesions. Here's a large cystic pattern of clear cell carcinoma. Again, you see there's variability in where the size and spacing of the nuclei. There's sort of a grungy, not dirty, but just granular appearance to the secretion. And on high magnification, we see, of course, the cytoplasmic clearing, the variability in the nuclei, hyperchromasia, some prominent nuclei in a few cells, and just some pleomorphism that makes them far greater than the grade 1 or 2 nuclei. And then here's a more solid pattern where we can see the sharp cytoplasmic borders between cells, variability in cell size and shape and location within the cell, as well as some surrounding lymphoid inflammation. Don't see here any inclusions. Here's another example of this clear cell carcinoma with more oxophilic cells, which is a recognized pattern as well that doesn't have the diagnostic clear cytoplasm that we would assign to most variants of this tumor. Here is an example of the hyaline droplets. You can see these eosinophilic cytoplasmic inclusions here that we've seen in other tumors, yolk sac tumor of note, but if found in an otherwise characteristic clear cell carcinoma can be useful in characterizing it and further supporting the diagnosis. Here's a tumor that's become very extensively hyalinized. We see the cords of tumor cells with clear to slightly foamy cytoplasm, but we have this very hyaline stroma without evidence of sort of glandular or cystic structures. They've been compressed by the stromal tissue. So in terms of immunohistochemistry and molecular analysis, NAPSIN1 and HNF1B are positive in this tumor. Didn't include the NAPSIN-A on this marker here. They tend to also be PAX8 positive, but they'll be negative with WT1, negative with the hormone receptors, and usually do not harbor a p53 mutation. In contrast, they do have ARID1A or PIK3CA mutations fairly commonly, and in the case of the latter, that may have a favorable impact on outcome. Again, routinely, we would do mismatch repair defect testing, do our MSI panel, and other pathways that can be activated in these patients are the MEK or MET pathway that can be adverse to outcome. So other tumors that can have clear cell cytoplasm or clear cytoplasm would include endometrioid carcinomas, some Brenner tumors, dysgerminomas, yolk sac tumors we've mentioned, struma ovarii, melanoma occasionally, Sertoli cell tumors certainly, steroid cell tumors, and some epithelioid smooth muscle tumors, potentially picomas, for example, as well. And then, of course, metastatic clear cell tumors from other locations like the kidney or the GI tract and so forth. But the key features we want to think about are high-grade nuclei and this characteristic phenotype. Again, going back, and this is where immunohistochemistry can be very useful. We use the NAPSIN a great deal and use these other differential markers when we need to do that. In terms of behavior, they do a little bit better than serous carcinoma. Surgical rupture is not necessarily a bad sign, but again, these are not, if you're going to put in your vote for what you'd like, you may make some better choices to get other tumors. Stage 1 and 2 do quite well, in fact, have very good survival, but if they're at advanced stage, the survival may decline significantly. Now, there's another grading scheme out there from Dr. Yamamoto, which groups these into 3 groups. Again, according to the histologic patterns that are present. If more than 90% of the tumor is tubulocystic or has the papillary pattern, that's group A, whereas group C is greater than 10% of the tumor is very poorly differentiated, has solid tumor or infiltrative single cells and no papillary or tubulocystic differentiation. And then group B is kind of in between. So survival corresponds to those groupings as well, but this is not widely employed. So let's talk briefly about the transitional cell tumors. These, again, are fairly uncommon. Perhaps Brenner tumor being the most common, and even that is, 2% or less. The borderline and malignant Brenner tumors are vanishingly rare. These are tumors of adulthood when they present, and the malignant versions are usually of epithelial origin, but there may be some germ cell derived tumors in there as well. Rarely would you see this as a variant in serous carcinoma. Borderline Brenner tumors will, of course, resemble a papillary urothelial carcinoma or papillary urothelial tumor with a component of some benign Brenner tumor also present. These may be mitotically active and would be graded according to other urothelial neoplasms. With high-grade atypia, we might, again, use the term intraepithelial carcinoma in our descriptive diagnosis. Malignant Brenner tumors, a little bit more widely studied or reported. We should see stromal invasion, and then probably still some element of a benign Brenner tumor to validate that we have this and can call it a malignant Brenner tumor. Otherwise, I think just a urothelial or transitional cell carcinoma is a better term. Here's an example of a benign Brenner tumor. This is a fairly large one, fairly solid appearing, and the microscopy would be fairly typical of that with these nested areas. Note the clear cells and occasional eosinophilic droplets or cystic spaces filled in with this. Sometimes on high magnification, you get really good morphology. Here, as you can see, these inner layer of mucinous cells beneath which you have the more stratified transitional type of epithelium. This does not make it a mucinous cystadenoma. This would be enough to call it a Brenner tumor. Here's a more aggressive one, a borderline Brenner tumor, where we get this very papillary tumor in a dominant cystic space, but other areas that were more characteristically Brenner. Here's the urothelial atypia that we'd see in these papillary projections in the borderline Brenner tumor. And then here's one where we have a benign Brenner component here on the left and an invasive malignant transitional type neoplasm extending into the stroma, making that diagnosis established. Now, transitional cell carcinoma is reserved for any of those circumstances where we don't have any residual borderline or benign Brenner elements remain. This can occasionally be mixed with other types of epithelium, serous or endometrioid. The immunohistochemistry, interestingly, tends to resemble that of the high-grade serous tumors. In other words, it's WIT1 positive, PAX8 positive, but it's less frequently positive with P53 or P16, and may be negative for some of the urothelial markers like thrombomodulin or P63 uroplakin. Raises the question, is this just a more solid variant of high-grade serous carcinoma that doesn't have fully evolved mutational status to make it into that category? And by virtue of that, it's a transitional neoplasm. That's a good question, and we don't know the histogenesis on all of these tumors because they're relatively rare and the molecular signatures have not been fully worked out, but it does tend to have a urothelial appearance. As you can see here, this is a clear-cut solid tumor with a very urothelial type appearance. And in the absence of any other Brenner elements, you'd call it transitional cell carcinoma. Here again, you see this sort of grade 2 pattern. This does not look particularly at all like high-grade serous carcinoma, although some serous carcinomas can have a solid component a little bit like this. Here's, of course, another feature that can be seen in transitional neoplasms is areas of squamous differentiation or glandular differentiation. And so finding those in one of these type of neoplasms should not be out of consideration. Considerations in terms of differential diagnosis would be metastatic tumor from urothelial location, relatively rare, undifferentiated carcinoma, high-grade serous carcinoma, undifferentiated carcinoma, granulosa cell tumor, maybe. Usually this would be more malignant looking than most granulosa cell tumors. Certainly transitional carcinoma has a worse outcome than a malignant Brenner tumor, but that may just be due to the other cell types that can be associated with it. Less common types of ovarian carcinomas, squamous cell carcinoma, pulmonary type small cell carcinoma, large cell neuroendocrine carcinoma, adenoid cystic, hepatoid, basaloid, oncocytic, and then this wonderful entity at the last, the small cell carcinoma of the hypercalcemic type, which we'll touch on. So here's an example of small cell carcinoma of the pulmonary type. We see a high-grade malignant, slightly glandular formation, more of the endometrioid type over here. And then here we see this small cell version, small cell carcinoma that would be staining positively with neuroendocrine markers. And here's an example. Large cell neuroendocrine carcinoma, more cytoplasm, bigger nuclei, still have neuroendocrine type chromatin pattern and immunohistochemical markers supporting neuroendocrine differentiation. Hepatoid carcinoma, abutting a serous papillary carcinoma. So a mixed feature here, hepatoid version. Here you see the abundant oxophilic cells, mitotically active, atypical nuclei, and a conventional serous carcinoma. So mixed type with both serous and hepatoid. Here's an adenoid cystic carcinoma. It looks very similar to what we'd see elsewhere. Basaloid carcinoma, very pronounced peripheral basilar palisading. These, of course, perhaps more commonly would be associated with a germ cell tumor where you're going to have squamous elements and so forth. So finding them de novo would be unusual. Here's a mixed tumor composed of mucinous cystadenoma with a Brenner tumor here coming along with it. So various wild combinations can occur. And here's a mixed tumor with squamous differentiation here on the surface and endometrioid differentiation down below. Here's again an endometrioid type of gland with undifferentiated small cell carcinoma. And in this situation, the whole concept of dedifferentiated carcinomas can come into play. And certainly when you see any very high-grade carcinoma in association with an endometrioid tumor, that should probably be your dominant diagnosis. And some of the undifferentiated carcinomas in the ovary will likewise probably have that kind of histogenesis. So let's spend some time here on the small cell carcinoma with hypercalcemia. We don't know the histogenic origin of this, but it is a fairly common undifferentiated carcinoma in younger patients. There have been some heritable associations. It was recognized when we detected these patients with hypercalcemia. And the tumors tend to be sort of large, solid, sort of creamy colored tumors, very friable, easily ruptured, and they may have follicles and sheets of tumors with nests or cords and occasionally some larger cells. So you can imagine from this that the appearance can raise the possibility of things like a juvenile granulosa cell tumor or adult type granulosa cell tumor and so forth. And here's this slightly lobular appearance, but you see a very soft, very friable fish flesh kind of appearance. And here's the microscopy. We see these follicular-like spaces, a very high-grade small cell malignancy in between the follicle-like spaces. And so this does have some resemblance to granulosa cell tumor, but generally would have a much higher mitotic rate. And then if you, of course, have hypercalcemia, that helps to cement the diagnosis. Here's the very undifferentiated small cell type of tumor, individual tumor cells separated with a little bit of stroma, and then nests and sheets of cells as well. Here's the higher magnification view. You can see these cells have a little bit of a neuroendocrine feel to them, very high grade, abundant mitotic figures, a little bit of a starry sky background associated with this as well. And here's an area where you've got these larger cells, sort of eosinophilic component to the small cell tumor as well. So unusual tumors with variants that can be somewhat challenging. Here's a large cell variant. This is a case where hypercalcemia again was present, and that helped to drive the diagnosis. Again, small cell carcinoma with an admixed mucinous neoplasm. And then these other cells with more clear cytoplasm. So these are things that could be misleading and make you think more of granulosa cell tumor perhaps, or of other type of mixed tumors as well. The immunohistochemistry can be helpful. So WT1 nuclear staining and EMA are usually positive, which you would not see in other small cell malignant neoplasms. But other stromal markers like calretinin and so forth, cytokeratin, calretinin, CD10, P53 also can be positive, although this is not associated with the P53 mutation. Occasionally you'll have synaptophysin positively or other neuroendocrine markers, but it will usually be negative for these more specific markers for neuroendocrine tumors. There may be some paraneoplastic hormonal elements that are associated with this, but they don't seem to be directly related to the elevation of calcium. So an interesting area for study. Differential can include granulosa cell tumor, we've mentioned, lymphoma occasionally, small cell carcinoma of the pulmonary type, peripheral neuroectodermal tumor or other small cell tumors, desmoplastic small round cell tumor. Dysgerminoma occasionally, especially if you have very many of the clear cell type cells and so forth. This is a high-grade malignant tumor and has may have widespread disease at the time of diagnosis. Even low-stage patients often are dead within 2 years as they don't often achieve a fully disease-free follow-up. Advanced age, normal calcium, absent large cells, and appropriate treatment with bilateral salpingo-oophorectomy, radiotherapy have had some survival advantage. So certainly don't lose all hope. Sometimes things go this well here. So I think we'll just conclude this discussion today with a couple of short vignettes with some less gruesome or less common lesions, but maybe some more benign lesions. So one of these is the cystadenoma of the rete. The lining would look much like a paratubal cyst in some ways, very low cuboidal type of epithelium, but it occurs in the ovarian hilus, in the rete. Occasionally, you can also get some associated Leydig cells or steroid-secreting cells along with that. Another lesion that we occasionally see in the ovary is leiomyoma. Cellular variants can occur here, so don't leave that off your list of spindle cell tumors. Vascular lesions like this anastomosing hemangioma or other vascular anomalies can also occur in the ovary. We mentioned that on the very first, that the vascular tumors, stromal tumors of non-ovarian origin can occur here. Here's an adenomatoid tumor. Again, we have normal ovary over on the side, and here we see the very lace-like pattern of rounded irregular spaces lined by a low cuboidal epithelium that would be positive for calretinin and cytokeratins. Another tumor that may occur in the peritoneum and involve the ovary is diffuse mesothelioma. This has slightly different risk factors than the pulmonary types as well, so bear that in mind. And differentiation from other papillary serous lesions can be challenging in some settings, but the utilization of PAX8 and calretinin and other mesothelial markers, CK5-6, can allow you to make that distinction. Here's a histologic example showing how it's just very stuck on. There's no parenchymal involvement in this particular case. And here's the microscopy, a very papillary tumor that would look very, very similar to papillary serous carcinoma and so forth. Other features that can be seen in the ovary occasionally are solid pseudopapillary tumor of the pancreatic type. So this is reported, very unusual tumor, and has the characteristic immunohistochemistry. I'll refer you to our video on the solid pseudopapillary tumors in the pancreas. Follicle cysts can sometimes become very large and be mistaken for a cystic neoplasm. Of course, the lining will inform you that this is a functional follicle with theca interna type cells and surrounding ovarian type stroma. And then the corpus luteum cysts, of course, easily recognized by their golden orange peripheral rim. Not infrequently have this hemorrhagic fibrinoid center. And here's the microscopic correlate. The steroid-containing cells form this band out here with an inner zone of organizing fibrin. Polycystic ovarian syndrome can sometimes produce enlarged ovaries and create problems, of course, in terms of fertility, and also lead to potential hypersecretion of hormones and non-cycling menstrual abnormalities, and potentially even endometrial neoplasia. So here's what the ovary looks like in that scenario, a very macro follicle appearance, otherwise normal appearing ovarian stroma. And many of these follicles are at a similar stage of development. None seem to be developing into corpora lutea or corpora albicantia. So one feature can be the absence of the presence of corpora albicans. Stromal hyperthecosis or thecosis, evidenced by a very prominent yellowish color to the stroma, and may be associated with extensive luteinization. What constitutes extensive, and when do you make that differentiation? I don't know that there's a quantitation that is available to make that distinction. If these are easy to find or I find more than one, I will usually make a comment, especially if we've got the typical stromal hyperplastic appearance of this stroma and find areas of luteinization. I would make the diagnosis of thecosis with luteinized change. Now, another entity that comes into differential considerations at times, and which is a little bit puzzling, is so-called massive edema of the ovary. And this is not necessarily caused by torsion, but seems to have a spontaneous component to it, where the normal ovarian structures are just separated by a very massively edematous change in the stroma. The follicles tend to be preserved. The corpora albicantia, of course, are scarred down, but the intervening stroma shows just a pronounced degree of edema. Fibromatosis can also occur in the ovary, and that's, of course, would be associated with the beta-catenin lesions that we would see as we see fibromatosis elsewhere in the body. Unusual to encounter it here in the ovary, but for fibromatous lesions that have that characteristic morphology and appropriate immunohistochemical findings, you can make that diagnosis as well. Here's what it looks like under the microscope, a very fibromatous bands of cellular tissue surrounding ovarian follicles without the normal theca type of investiture around the follicles. Hyalus cell hyperplasia, we mentioned this briefly in the differential of the steroid cell tumors, but nodular rests or steroid secreting areas can be found in the ovarian hyalus. Occasionally you might even see crystalloids of Reinke, and this would fall into the category and the spectrum of steroid cell lesions in the ovarian hyalus. And if it's functional and larger than 1 millimeter or 2, then usually you would move it into the realm of a tumor rather than just hyperplasia. During pregnancy, patients, of course, develop a corpus luteum, but on occasion, this process can persist or develop in another setting in which you get multiple luteal nodules, luteinized nodules in the ovary as well. And this is an example of the hyperreaction, hyperreactio luteinalis, showing one ovary here on one side and the other ovary. Both ovaries pronounced cystic changes with luteinized changes evident under the microscope, as we see here. Lots of luteinized cells within the stroma as well as in and around lining these follicles. So then just to sort of conclude with some comments on staging, I think it's important to be familiar with the notes about all of these primary tumors that can occur in the ovary and the staging questions that can arise. We use the College of American Pathologists checklists. They're updated regularly. This is a much older edition. There is a 2020 edition that would have the most recent information. And not just to look at the checklist items, but to spend some time studying the notes that apply to the various checklist items can really help you to refine your diagnostic skills and your differentiating skill in dealing with these lesions, and especially these tumors in the ovary that we've been talking about over these last few videos. So with that, we'll come to the conclusion. I always welcome your comments. Please subscribe to our channel so you don't miss future contributions. We welcome your comments and feedback. Those have been very helpful, and we look forward to seeing you here on the channel again at some future date. And so thank you very much for joining us.